The important thing, I guess, in terms of talking about innovation is the fact that one of the challenges we've got, and one of the things that the wonderful, delightful Ellie has done in setting up these leg clubs and leg club conferences, is finding a home for patients with chronic disease where they're welcome, they're supported, and their health and their social needs are actually looked after conjointly. One of the things that we need to recognise is that there are problems, and there are real problems out there. I will pass no comment on the individual referred to here, but the thing I find fascinating, and perhaps you don't, is they talk about his swollen legs and chronic venous insufficiency as a particular problem. But nobody mentions the Coke bottle that's next to his ankle. And one of the things that is interesting is to recognise that the wound doesn't exist in isolation from the patient and their community and their culture and all those other things. And we heard that earlier today. And you can see I'm an evidence-based practitioner because I actually use the Daily Star as a source for my information. But, you know, times are changing. We need to recognise that our current government, please note neutral tone, is battling with the challenge, and Naz said earlier on about sort of throwing money at it. It's not going to, and it is important, I think, to recognise that throwing money at things is not going to achieve benefits unless we do other things at the same time. And one of the things we need to recognise, and all I've done is just took it at a broader view, look at the global problem. The problem of chronic wounds on a global basis is about $350 billion. Looking at the numbers increasing with an increasing elderly population and looking at the cost increasing on a global basis. Why is it, at a time where we can transplant many organs, cure many cancers, we can't guarantee that a patient with a wound sees somebody who knows what they're doing and those individuals have something effective to treat those patients? It is important to appreciate that. The other thing that's also important is we assume they're all the same. You've got a hole in your leg, you've got venous disease, you've got a venous ulcer. Now that's a very simple, very sensible, in an understandable way of looking at it, but it underpins or undermines the complexity of what we're looking at. Venous disease may be the commonest cause of problems with ulcers on the legs, but it's not the only disease that can be there. And I think the important thing is to recognise, in terms of the therapeutic armamentarium, and I have no problem with dressings, I have no problem with devices, I have no problem with surgeons. But one of the things I do have a problem is, why haven't we got any effective drugs? If this was another chronic condition, rheumatoid arthritis, Parkinson's disease, you would not look to treat conditions such as that without having a drug, whether disease-modifying drugs or symptom relief drugs. The important thing is to recognise that we are hampered by the fact that what we've got is a limited range of therapeutic interventions. The other thing that's also important, this comes from David Armstrong, who's a colleague of mine, who's based in California, looking at the frequency of different malignant diseases and the frequency of diabetic foot disease and the frequency of non-healing wounds. I'm always puzzled by this thing. Why is there such a difference in profile between cancer, which I have no problem with, because if it's me, it's my family, it's my friends, anybody else, I want them to receive best care. But if they've got a chronic wound, well, you just have to put up with it. It's part of aging, it's part of having diabetes, it's part of all these other things. But people will tolerate that and accept that as reasonable. Why? I'm not saying we reduce the profile of cancer, but how do we get chronic wounds coming up to the same level or even perhaps a bit higher, because we've got a lot of catching up to do and things are changing. And this is looking at the US versus the UK, looking at the economic burden of diabetic foot disease. And yes, we have these data to actually suggest that cancer costs the same as wounds, or wounds cost the same as cancer. But why is there that difference in profile and that focus on education and research? The other thing that's interesting, and I've had a very checkered career, as Jackie will testify, that it's not all about money. It's a complicated slide, but basically the two boxes with the red around the outside on the right-hand side, this is looking at wealth in countries and the frequency of major low extremity amputations. And Singapore, which I spent 5 years working part-time there, developing a national wound registry, is not a poor country. It's a very wealthy country. But why, and it's at the bottom, because you probably won't be able to see it on this on the slide, is the frequency of amputations in Singapore. So it's not just about money. If you want something in Singapore, you can get it. But what you have to recognize, there is no direct correlation between wealth of a nation and the frequency of lower limb amputations. You could argue that diabetes in Singaporeans is a different disease, is much more aggressive. And they certainly see far more ischemic disease than we do here. So how do we bring about change? And one of the things that I'll leave to you as my pearl, maybe you'll get a couple of little ones as well, is the business about innovation as a blanket to put over this thing that gives you dignity and credibility. If you talk about wounds, wounds are difficult, wounds are awkward, wounds are smelly, I hate wounds, I don't do wounds. If you talk about innovation, increasingly in health services around the world, there is the acceptance that translational research or practical research or delivery research is becoming more important, and that's where innovation is a dignified cloak to actually put around the thing. And innovation can come from anywhere, and this is just a guy who's using what's the word? Angry Birds. Angry Birds was a great way of trying to develop a teaching course for surgeons on orthopedic problems. Who would have thought that you could cross-fertilize that? We tend to think of things in a linear basis, and I've got to look at it in a model, I've got to look at it in an animal, I've got to look at it in patients, and we develop everything that way. But this is cross-fertilization across different furrows to actually bring about change. And this is my concept, which you may agree or disagree with, about the potential for clinical innovation and the 5 Eyes model that we published in the British Journal of Dermatology a few years ago, and say that a clinical innovation institute, which can manage all sorts of chronic diseases, there's 5 Eyes to it. There's the impact of what we do, there's the invention that we can create, which may even help with the financial state of the NHS, filing patents and sorting out the development of startup spin-out companies. There's innovation on its own, which I'll come back to in a second, and there's implementation and improvement. So all of those 5 things have been mentioned at some stage today. The important thing is to recognize it's becoming an accepted science. Those 2 are books that I picked up this week about innovation. And this is from one of those books, which is the MIT from Boston 5 stakeholder model, where basically it's saying all of these stakeholders are key members of that MDT approach. I've taken the 5 Eyes model and just expanded it a little bit here, so you can see the 5 Eyes of impact and implementation, etc., and there's components of that listed in there. In innovation, there's technological innovation, there's system and service innovation, and there's also social innovation. And that's becoming increasingly important with the current government and their plans for the NHS. You'll also see the potential for going up the middle of the thing at the top, a global network, a network of centres that actually share that philosophy, share that approach, and we can learn from each other and develop best practice. And I think this is something that we should consider, because bearing in mind what I've already said, this is a history of wounds. No one's interested, no one's in charge, no professionalism, no investment, no recognition or acceptance, and no legitimacy. Sad. Old fogies like me have been doing stuff in wounds for 40 odd years. Have we really made any progress in those 40 years, or do we still go in, and I forget who said it, somebody said it this morning, about apologise, I've come to see you about your wound. It's only the wound that we're interested in. And what I've been interested in for a number of years with colleagues including Jackie, is creating a clinical specialty. What is a clinical specialty? But allowing us to have monitoring roles and coordinating roles across patients with wound types. But the important thing, as we look at, this is me looking forward to the future and trying to get some pearls out of it, is the fact that increasing awareness and profile of wounds, better care is possible, and we've all of us, if you come to this meeting, I bet you've got better healing rates than anybody else who work alongside you, who hasn't come to this meeting. Just having an interest will make a difference. We also need to recognise there's increasing complexity of multi-morbid patient pool, and the variation in care provision at all levels. Apart from burns, there's no accepted standard or template for good care. Now, it's fine if you've got a burn wound, but it doesn't help if you've got a leg wound, a chronic ulcer on your leg. The important thing is and Naz certainly said this, was a business about an MDT approach. Now, the academic purists would say it's not an MDT, it's not a multidisciplinary team, it's an interdisciplinary team. Because everybody within that interdisciplinary team has a vote, has a say, and everybody's listened to. It's not the grey-haired consultant has gone, he's buggered off again. Oh no, he's there, feeding his face. The important thing is to recognise that we all can contribute something, and none of us have a monopoly, not even the vascular surgeons, and certainly not the plastic surgeons, in managing all patients with wounds. We can all bring something to it. The other thing is education and training is not consistent. What defines a specialist? Now, depending on your professional group you belong to, it'll be different. The important thing is to look at the educational paradigm that looks at knowledge gain, skills acquisition, and behaviour change or outcome data. Those are the things that I believe we should be doing if we're going to be seen as a recognised specialist. The other thing is that at this moment in time, although it is changing, the role of Royal Colleges and training boards in North America is changing, where they're now starting to accept that wounds should be part of the training program. Interestingly, in the UK, for vascular surgery, they need to know about diabetic foot wounds, and they're supposed to have training in it. Geriatricians are supposed to have training in pressure ulcers. The important thing is many of those things are in Royal College training handbooks, but not many of those registrars going through the system actually get access to it. As well as trends globally, there's also trends in provision of wound care in the United Kingdom, and basically to save time, there's a lot of them out there, they're increasing in number, we still haven't cracked the problem, and what we should be looking at P4 systems of care for chronic disease, including wound problems, predictive, personalised, preventative and participatory co-production of the patient involved in the team that are making decisions on the patient. I can put that into a slightly more layman phrase and call it right patient, right time, right treatment and right outcome. That's what we should be striving for. But we're a long way away from achieving that on a consistent basis. Aradazi was mentioned earlier today, and the 4 pillars that he talks about, main pillars are here: re-engage staff and patients, care provision closer to home, much more in the community, not in big shiny teaching hospitals. Simplify and innovate NHS care, drive productivity in hospitals, use new innovative technology that works, not because it's somebody's pet project or somebody's favourite toy. We can contribute to the nation's prosperity and make the service deliver. Let's look at data. If you've got no data, you've got no problem. If you've got data, my gosh, it's a big problem. It's common, it's expensive, and it's challenging with bad outcomes. But this, the interesting thing is the ICS, ICP thing, where there's actually looking at a comprehensive care and social care, healthcare and social care for a defined population. From God's country, otherwise known as Wales, we only have a population of just over 3 million, but that's the same size as Manchester. And a lot of the ICBs are built on that 3 to 5 million base population. And that's important, because the interesting thing is if we're going to talk about health, we also talk about social care. If we're going to talk about treatment, we also talk about prevention. If we're talking about acute care, it's also chronic care. We're talking about short and long-term follow-up. Why are these strange people from Wales who talk funny and they have too many letters in their way and they, well, I never. Why did they come in Wales? It's all serendipity. Again, it was innovation. Not me. I just happened to be in the right place at the right time, and I was stupid enough to say I'll give up other things in my potential career to focus on wounds. But this is how it all started for us, and it was my hero and mentor, Les Hughes, who was a professor of surgery in Cardiff, who invented silastic foam dressing. Most of you have never seen it or heard of it. It's no longer available, but it's known as the Cardiff bum bung, because it was used to treat patients with pilonidal sinus disease. And it's a silicone-based material, and because Les Hughes invented it, Les Hughes filed the patents, and he got the idea from dental impression molding material. We actually had a company interested in putting money into it. And this is a Cardiff bum bung. It's the silastic foam stent in a pilonidal sinus wound. Mistake we made in a big teaching hospital was put a sign on the door and call it a wound clinic, because suddenly they came from everywhere. We gave other clinicians in the hospital a chance of dumping the patients somewhere else as long as somebody else looked at it. They didn't care. I just need to get rid of this. And the Welsh Wound Innovation Centre, which unfortunately is a casualty of COVID, was a model that we developed of linking academic, clinical and commercial components and stakeholders together working on chronic wounds. I've mentioned that this role I've had in Singapore, which is the SG patients with chronic wounds, where we did this prospective registry of over 800 patients. And the important thing is to look at the problems that we have here in terms of comorbidities. 76% of them had high blood pressure, 75% had diabetes, 79% had dyslipidemia, 12.5% had chronic heart failure, 43% had arterial disease. Wounds do not exist in isolation, and somebody or some bodies have to work together to try and manage the patient rather than the hole in the patient. Some of our other research and interests that we've had as being innovators is this concept that in this patient, is there a skin cancer? Is there an acute wound where we may have taken a biopsy to make a diagnosis? And is there a chronic wound? But do any of us know where one starts and one stops? And where's our diagnostic test? Because that will be labelled very easily and quite confidently by many clinicians, that's a venous ulcer. But our hypothesis was you could actually look at the spectrum where in the middle was acute wounds or normal wound healing. At one end was a chronic wound that didn't heal. At the other end was a malignancy. Now some wounds do transform themselves into a malignancy, but some of the processes in malignant transformation and malignant disease are similar and some are different to what you see in wounds. Wound healing is a complex physiological, pathological process, and we need to recognize that, and we need to appreciate that we really barely scratch the surface at the moment. And this is the work we published in the British Journal of Surgery in 2019, where we were looking at venous ulcers, this gene work, where basically here is our 14 gene signature that enables me to be able to differentiate a chronic ulcer that's going to heal from a chronic ulcer that doesn't heal. So rather than treating all leg ulcers with the same thing, you need simple treatment, you need something different, you need something more complicated, and you may need stem cells. You may need placental-based products. And this is the study with the statistics on it, which is me pretending I'm an academic and baffling you with bullshit. But the important thing is that it's happening in other areas. This is from the Times, where in prostate cancer patients, they're saying, because we know there are two types of prostate cancer. There's one that grumbles on very slowly, and ones that develop very fast and aggressively. What we want to know is to find the ones that are developing aggressively and intervene earlier to produce a better outcome. And this is from earlier this month. So this is hot off the press. Now they can look at personalised or precision medicine for prostate cancer. Why can't we do the same thing for wounds? The other thing that's interesting, and I think Beverly touched on it in her presentation, yes, we want them to heal when they have the potential for healing, but we cannot have magic powers coming out of the end of our fingertips that'll heal everything. And this is a survey from patients in the United States. We're asking patients what would they want from treatment. And they want to improve ability to walk and do things by themselves, reduce amputation, reduce infection. I'm not saying they didn't want it to heal, but the healing was not the driver. There were other drivers that these patients were saying that they were interested in to move things forward. The other thing that's also important, and one of the problems that we have in immature subject of wound healing, is the fact that some of the stuff we do routinely, but doesn't work. This is interesting from the US, where they're now talking about taking surface swabs from chronic wounds is a complete and utter waste of time. Now, many of us in this room, I suspect, have been saying that for a number of years, but it's still prevalent in any part of the world that I've been to, that's how they do it. Take a swab. If you've grown a bug and it's a Staph aureus, it must be infection. Patient's fine. Wounds are healing better. Wounds are getting better. Why aren't we looking at what the patient's doing, what the wound's doing, rather than what the lab tells us that they've grown on the end of a stick? I talked about multidisciplinary teams. This was another editorial that I was asked to write for the British Journal of Dermatology. Rather than spending huge sums of money for patients who have regular dressing changes both in hospital and the community, should we not be creating teams in clinical areas and facilities where patients with chronic wounds are supported by an interdisciplinary team that includes a wide range of professional disciplines, including doctors, nurses, podiatrists, and professions allied to medicine? That's words I used. All right? Important thing, I did not say that the doctors were going to muscle in and take over. I said there should be that team working together and working together harmoniously. The other thing that's also important from an article in a scholarly review was we need to appreciate many treatments have potential, but there is no magic bullet. Reminded of a quote by Winston Churchill, for every complex problem, there's a simple solution, and it's always wrong. So let's stop trying to reduce this to the bare minimum and find the magic bullet or magic way of doing things. Let's recognize this is diverse and complex. And this is how I described how I would assess a patient. You won't see it, and it's not meant to confuse you or complicate it, but down the middle, I assess the patient and I assess the wound. I make a diagnosis. I look at treatment options. I look at treatment goals, and then I'm going to follow them up to see if they get better. That's the medical model, and that's the medical model that I feel is missing in many of these patients. The other thing that's also important is to recognize my therapeutic armamentarium runs through the middle of it, is the dressings, devices, drugs, surgery, and biological approaches. So I'm not saying that we shouldn't try and make it as practically feasible as we possibly can, but to recognize if you do the reductionist thing, there's a simple magic bullet out there, you'll be bitterly disappointed. The other thing that's also important is to look at the things that are changing in the health service and where it's going. And this is just an attempt to look at all the bits of the health service that a patient with a wound may interact with. And when they interact in those different bits, they may be seen by different people. And this is an attempt to actually look at a staged approach from 1 to 6 at who should be looking after those patients based on complexity. We've recently heard a lot about the 10-year plan for the future, and this is just a poster from it. But yes, great idea, but do we really know what we're doing? And this is something I've recently got interested in, which is the real lived experience of having wounds and the impact. And there are those 5 domains that are in bold there and all the subdomains underneath them. And this is just a summary of part of it. And we need to recognize that this work by Lawyer is actually going to take us further forward, because it's not going to be just healing rate, it's not going to be cost effective, it's not going to be just quality of life, it's going to look at these things. So in conclusion, wounds are common, wounds are expensive, wounds are challenging. Healthcare is changing. Innovation, I believe, is a key element of success. Multidisciplinary teams are needed. Patients want healing, but also want to maintain normal activity and functioning. Comprehensive assessment by clinicians is needed. Health-related quality of life measures exist, and the real lived experience is an interesting new concept. So we've gone from no evidence to case series, to RCTs, to cost effectiveness, to quality of life, to registries, and then real world experience. So the important thing is recognise changes is happening. The other thing that's interesting, and again from the Times, or not the Times, it's the Yorkshire Times, this is about ICBs now threatened with budget cuts. And this is when in West Yorkshire is going to have to lose 400 members of staff. How on earth do you do that when you haven't even got the money to pay their pension? So am I an idealist or a pragmatist? I dreamed a dream. Can we have a global network of centres focused on wounds to actually improve the care of many of these patients? Thanks for your time.